Good morning, good afternoon, good evening to everybody. Today we'll be talking about challenges during hysteroscopy. So when we're doing hysteroscopy, there are specific steps and processes we will be following and the guidelines to have a safe hysteroscopy. But when you do enough, you'll definitely come across a certain type of scenario where you would get some challenges during the hysteroscopy. So let's discuss a few of such challenging situations. So what are the types of challenging situations we could encounter? Well, we could be challenging situation about entry, so entry into the uterine cavity, challenges about a false passage, for example, challenges about the vision challenges, so you don't get a good view, challenges about bleeding, and challenges like perforation or complications related to such. So if we take on one by one and we talk about a difficult entry. So what is a difficult entry? A difficult entry could be due to either a cervical stenosis or a block. That could follow in situations like a previous conization or a large loop excision of the transformation zone, a previous curettage and damage, an Asherman syndrome case, trauma to the cervix, or a Manchester repair where part of the cervix was cut off, or like a trachelectomy. So these are challenges that would lead to difficulty in entry. We could also have difficult entry in some form of, let's say, an abnormality in the structure. So anatomical distortion could be even an acutely anteverted uterus or an acutely retroverted uterus, or a uterus with multiple other pathologies inside. That could be one. Another challenging situation could be a situation where there are adhesions and a fixed direction of the cervix, because with your rigid hysteroscope getting in, you need a little bit of flexibility of mobility of this uterus. So assuming the uterus is ventrofixed, for example, it's fixed to the anterior abdominal wall due to previous surgery, it's going to be a problem. Assuming it is anteverted and retroflexed because of endometriosis, which could be severe deep endometriosis, it's going to give you difficulty entering this cavity. So what do we do about difficult entry? How can we solve this problem? Problem number one is we could use something to pharmacologically dilate this cervix, allowing a little bit of laxity in the cervix to allow an easier entry in stenotic cervixes. For example, a misoprostol used before hysteroscopy. It may not be that effective in postmenopausal women because it doesn't respond that well, but it's very good for premenopausal women. And let's say 400 micrograms vaginally 6 to 8 hours prior is something I have used before, but even at 200 micrograms given the night before orally or sublingually is actually an option and helps with the cervix preparation. We now also have possibility of mechanical dilatation using Hegas in very difficult situations, but there remains a risk for false passage or injury or damage to the endometrial lining as you're entering, which gives you a difficulty in viewing or assessing the cavity. We also have ideally entry under direct vision might be safer than blind dilatation. So is that an option? Well, I would say the best option would be a vaginoscopic entry where you're going in under vision and seeing each level as you're proceeding inside. We could have hygroscopic dilatation done using laminaria tents, which are hygroscopic rods of dried seaweed, which can be put in 24 hours prior, but they also have synthetic versions of the same that can be acting more quickly. That can be used to dilate the cervix slightly to allow an easier entry. We also could use the principle of hydrodilatation or facilitation, where under direct vision using the hysteroscope, you actually have the fluid that is in front of you with the hysteroscope, in this case saline, that is actually going to be used to guide you on the way forward. So it is safer as the instrument is advanced millimeter by millimeter under direct vision. It has less risk of false passages as well, and less risk of digging into the either anterior or posterior wall of the endometrium and the wall, so that you don't get a very clear view. You actually have a view with some damage of the lining, which we don't want. And we use the pressure of the fluid here to direct us in. Please remember, it's important to know that when you're going in with a 30-degree scope, you'll have to learn how to get in so that you actually have not going to be damaging the lining as you move on. So with a 30-degree scope, with the light downwards and therefore the view upwards by 30 degrees, you try and bring the mark of the hysteroscope to a 6 o'clock at the entrance. So the hole should be at the 6 o'clock mark when you're going in. Do not put the next hole in front of you in the center of the view, otherwise you'll be digging into the posterior wall as you go in. So this is very important to understand about the direction of holding the scope as you're putting it in a 30-degree scope. Should there be stenosis, then what are our options? You could have the option of dilatation with the scissors. So use a 5 French hysteroscopic scissors, put it in the operative port, and advance the scope while opening ahead using scissors under vision. We could also use dilatation with the scope itself as you move in. So you push it in, come back, see the view, then again direct it, push it in, come back. So you could use that, you could use the scissors, you could use a grasper to just open up bluntly in front of you as you're proceeding. So basically speaking, this is about entry and challenging entry. We could also, in some cases, require ultrasound guidance externally, abdominally with a full bladder to guide us on the entry in such difficult cases, either with the sound to direct it or the scope as we go on through a difficult to define external and internal os. But as we've said, the bladder will need to be full for this and have a second assistant who will be guiding us from above. Another way could be to operate during the menstruation. So you could use the trail of the blood and mucus to actually guide where the next opening will be and follow through. Although there'll be a disadvantage of the view being a little bit obscured because of the blood in the cavity, but it will definitely help with the entry into a cavity that is difficult. If we have severe stenosis, then obviously we can put in a cruciate incision, but remembering that the internal os is a horizontal slit, and therefore if you have to open it, you open it horizontally rather than vertically. But then you can, if it's closed right from the external os, you can make a cruciate incision and then proceed to follow the cervical canal with the crypts of the cervix up to the internal os and then open it up horizontally, as we've said. The next challenging situation would be a false passage. So how do we know we are in a false passage? Number one, we may not see any tubal ostia, so we don't see a full cavity. We see a narrow straight line where the scope has gone through. You don't see any internal or internal os, and basically the ostia of the cavity. Along with that, we may see muscle fibers. So when you realize you're between muscle fibers, please keep in mind you may be in the wrong place. So what do we do? Number one, slowly remove the scope, not fully out, but slowly remove the scope as you look around to see where the next opening of the true cavity might be. Number two, if you still don't manage it, then my advice would be discontinue, because you may have a lot of fluid absorbed through the injury, and adequate distension may not be possible, and you have the risk of perforation. You could then delay the repeat procedure to 2 to 3 months later. But in most scenarios, as you withdraw and you come out, you may see the next entry point and then direct ourselves to the new entry point into the cavity. But false passage can be challenging. If you also stop the inflow for a second, you will see actually there'll be bleeding coming through, because a false passage with muscle fibers is going to be quite vascular. So it will be another guide to tell you I'm in the wrong place. How do you prevent this? You can prevent this by dilating the cervix slowly and stop as soon as the internal os is reached. So that is if in case it's a very difficult scenario and you have to hold the cervix, dilate it, and then go in, which is not ideal because the best way would be to enter vaginoscopic. Then put the scope into the external os, leave the inflow open and the outflow shut, and let the pressure of the fluid slowly help with dilatation and show you the next step. And obviously insert the scope with the direct vision and the correct orientation based on the degrees of the scope. When you get a lot of bleeding in the cavity as you're going in, or let's say it's during periods, or you're in the wrong place, or you've hit something and it starts bleeding, then you may get what is called a Japanese flag effect, which is just a red circle all around the scope. So your whole view becomes red. When you see a Japanese flag effect with the vision jump, what does it mean? Well, it could mean the intrauterine pressure is low, or the flow is less, or the fluid is over. And if there is more bleeding, then actually can be removed by the outflow, or the outflow is for some reason blocked, then you will get this effect. So one, try and check your fluid. If it's fine, make sure your pump is pumping it well at the right pressure and the right flow. Then check if the outflow is blocked, because if it is blocked, then you will not get the debris come out and just give you an obscured view. Check if you've hit a vessel or inside that may need to be corrected. If this is blocked, you could use a syringe and actually suction out some of the fluid that is from the outflow tract to be blocked. But your first step should be stop. The reason is you do not proceed with the procedure like a hysteroscopy if you cannot see. So stop, look at the fluid, check the intrauterine pressure, check for bleeding, and then proceed with the next steps accordingly. It is more common when you've breached the endomyometrial junction, which means within the endometrial cavity, unless the patient is in her periods, you actually do not expect the bleeding to be something that will be significant. Yes, it will be seen more often in case surgeries like myomectomy or in transcervical resection of the endometrium. So if you're doing resection of the endometrium, and sometimes in Asherman syndrome and in the wrong plane, then yes, you will probably breach the endomyometrial junction and you will get more bleeding than normal, giving you the red flag effect. How do you manage this? Well, as you've stopped the procedure, if the bleeding is still a lot, you may need to tamponade the bleed area with a Foley's size 8 or 10, that's a pediatric Foley's, and put into the cavity and then balloon it with around 3 to 4 cc, and it will actually tamponade the cavity and the bleeder. Pack sometimes may be necessary with gauze, maybe that's diluted that is soaked in diluted vasopressin. And sometimes you may actually use a bipolar needle, hysteroscopic bipolar needle, and actually cauterize the bleeders directly. So this is how you would manage the bleeding and the red flag effect. Now let's go to perforation. Well, if you have a perforation, and this is common in certain kinds of scenarios when it's a difficult case, like Asherman syndrome, or an awkwardly positioned uterus, or a case where you are doing resection of a fiber that was a bit deep and you aren't aware of its depth into the cavity, then yes, it can definitely cause a perforation. And it is also seen more in resection of the lateral and fundal adhesions. So we have to be very careful near the ostia and the fundal area, posterior wall or anterior wall. That is very easily prone to perforation. How do we diagnose a perforation should that happen? Number one, the cavity will collapse, the view will become obscured, and the walls will fall onto the cavity. Why? Because the distension will suddenly be lost. Number two, there'll be rapid inflow of the fluid. So the pump will start pumping in faster because there is no obstruction to the flow anymore. And you will sometimes start seeing bowel or omentum in your view. So you have to be careful when you see that. And finally, your scope goes in much further than what it's supposed to be. So if your scope goes in further than the 8 or 10 centimeters of the size of the uterocervical length, then definitely you know that you're in the wrong place and you probably have gone through. So in case of a perforation, what next? Well, it depends on a number of factors. Number one, it depends on how quickly you identify the issue. It depends on what perforated the uterus. Was it a cold instrument or was it a hot instrument? A hot instrument means an instrument with energy. So if you are using a resectoscope, a bipolar or a monopolar resectoscope, and that's what perforated the cavity, then yes, you have to be extremely worried because the energy could actually have injured bowel out in the abdominal cavity. But therefore, if it is energy that has caused the perforation, then without any doubt, a laparoscopy needs to be done to check on the areas in the cavity and the pelvis that could be affected by that energy device. But if it is a cold instrument like a hysteroscopic scissors, or even for that matter, if it was the scope itself, then we can observe, because many times the muscular structure of the uterus with compression can actually control the bleeding on its own. So you can observe and see if the patient needs any further intervention or not. But how do we prevent perforation in the first place? Well, if you are using a resectoscope, then please apply current only when the electrode is moving towards you as opposed to away from you. So you know you're going from distal, coming closer. You will not be going from here, going distal and perforating it by mistake. Doing a simultaneous ultrasound definitely helps and in extreme cases, if you can do a double setup where you're doing a hysteroscopy and having a laparoscope in there on another screen, looking at your entry and seeing that you're not going to perforate is very important. We now talk about embolism. This is definitely a challenging situation, but more of a complication. I think we'll cover it more in the complications. But just a brief, we could get embolism of gas, in which this was used sometimes. It's formed sometimes from the use of energy, where you see the bubbles because of electrosurgery, which is gas, or in previously when we used to use CO2 for diagnostic hysteroscopies. And these emboli seem to be resolving rapidly. But then sometimes you get room air emboli, which is very dangerous and very likely to be fatal as well. So certain tips and advice on prevention, which is actually the way to be, because treatment becomes extremely difficult and is quite challenging. Make sure you purge all the air from the tubings before introducing the scope in every single scenario. When you are the user, you don't rely on someone having done it. You have to do that yourself and purge all the air from the tubings. Avoid a Trendelenburg position for hysteroscopy. It's always done in a flat position. Do not do a head low for hysteroscopy. Remove, if you dilated it, remove the last dilator just before inserting the scope and not before. And avoid or limit repeated removal and insertion of the scope. So wherever possible, do it in one sitting, because when you remove and reinsert, you take the risk of reintroducing some air. Make sure that the tubings, the pump is used with a fail-safe of stopping immediately the fluid ends, and you use fluid bags as opposed to fluid bottles because the fluid bags will collapse. Number 3 is you use large volume bags of fluid, so 2 to 3 liter saline bottles are better than half a liter or 1 liter bottles because you need to change them less often. You make sure you use the right hystromat and pump for fluid delivery system, and not use gravity or external pressure whenever feasible, and definitely never the external pressure with a pump that is inside the bottle. You use intracervical vasopressin, can be used to actually reduce, because it decreases or causes vasoconstriction and would not leave very many open channels for the embolism. And you can also make sure that therefore you have the right settings of the pressure, of the flow, and the right equipment knowledge. So this is some methods of prevention. So always safety first. Please, let's remember hysteroscopy is a procedure that's very technologically dependent. It's a potentially very dangerous procedure. It's not a minor procedure. It might be minor in terms of duration and how it's done, but it's potentially very dangerous. And please proceed with hysteroscopy only with good knowledge of the equipment and the technological know-how. Thank you very much.